Thank you for tuning into the OSSIO webinar, Bio-Integrative Implant Fixation with OSSIOfiber Intelligent Bone Regeneration Technology. We're honored to host this with two expert surgeon presenters. The first is Dr. Luke Cicchinelli. He is fellowship trained and currently practices throughout multiple clinics in Spain. Dr. Cicchinelli is the co-principal investigator for OSSIO's first in-human clinical study in Europe. Dr. Cicchinelli will be presenting the science behind OSSIOfiber and the results from the clinical study, most recently the one-year follow-up. Our second presenter is Dr. Chris Hyer. He is fellowship trained and currently practices at the Orthopedic Foot and Ankle Center in Columbus, Ohio. Dr. Hyer is one of the first surgeons in the US to utilize OSSIOfiber technology in his practice. He will be presenting the FDA-cleared first commercial product with the OSSIOfiber technology, as well as the pipeline of products with OSSIO, many of which Dr. Hyer has seen firsthand and trialed in cadaver labs. Without further ado, I'll hand it over to Dr. Cicchinelli.
So we all know certainly that metal fixation, be it stainless steel or titanium, certainly works very, very well. And this is an alternative to that. And it's not that metal fixation isn't good. We all use it and we all have good results, but it certainly creates a suboptimal healing environment and creates possibilities of, as you see in these slides here, breaking of implants such as in syndesmotic screws, possibilities of infections due to the adherence of glycocalyxes and bio-slime layers to fixation, sometimes still percutaneous fixation, cystic changes, sometimes needs for removal, secondary procedures. And I think really the question is about why is there a suboptimal healing environment?
And really the answer to that, in my view, is that because they're viewed as foreign bodies by the body. The body views them as material that needs to be essentially dealt with in some fashion. And in some issues, sometimes that's more inert than others. But nevertheless, they're looked at as a foreign body by the body. And so the desire to replace metal is not something new. If we look at from 1775 to 1995, a span of 200 years, you know, the first absorbable screws were released in the United States in 1995. So after a couple hundred years of use of metal and so forth, people became interested, and now that's obviously, you know, going on 30 odd years ago now. So the desire to replace metal is not new. And certainly the other products out there over the last 20 years, 30 years has been PEEK, the biocomposite industry of mixing the biomaterials, the polysorbs, the polymers, the biopolymers, and copolymers, and leading right up into the technology that we're so excited to be sharing with you this evening, which is the Bio-Integrative technology by OSSIO. And I like to cover a little bit of it historically and scientifically, but also my own interest in this. This has really been my primary academic interest in my career, quite frankly, since the residency days, which was 1990 to 93 for myself. And just going back here, 1984, so 36 years ago, to give a little frame of reference there, a fledgling company called Apple released the Macintosh computer and advertised it. They advertised and released the Macintosh computer in 1984, 36 years ago. And 36 years ago, the scientists and the surgeons and the researchers and the clinicians in Finland at the University of Helsinki in Tampere, Finland, were already publishing their initial results on absorbable screw fixation as it applied at that time to ankle fracture surgery. These were polyglycolic acid screws, PGA. Many of you who trained in the area that I did certainly are familiar and remember Dexon suture. I don't think Dexon suture gets used much anymore, but anyway, Vicryl suture and Dexon suture were the original absorbable products that these researchers developed in the 60s. And then that led on to the development of absorbable screws. So 1984, and in fact, again, 36 years ago. So graduating residents and fellows of any specialty today that are entering private practice and clinical practice right now, or even this year or next year, were not even born then. So just to give a little historical perspective, which I think is kind of fascinating. And then a study here, 1992, which was the published 1-year follow-up already. So the minimum 1-year follow-up. And so even in ankle fusions, absorbable screws were being used completely, solely absorbable fixation in the early 1990s. Our experience in the foot was the first use in the world in 1994 when I was practicing right out of residency, and I kind of baptism by fire, a little bit of a wild hair, but moved to Spain with my wife. We just married and no kids, and I decided I was going to try to learn Spanish. And at any rate, here with Manuel and Javier, dear friends to this day, both still in Madrid, we were trying to, you have to realize a few things. Cadaver surgery was non-existent in Spain at that time. Fracture walker boots were non-existent. Surgery was just minimal incision surgery. And we were trying to get a proximal weight-bearing osteotomy to allow patients to immediately weight bear in a surgical shoe right out the door. Open surgery, teaching them open surgery for the first time in their careers, doing open surgery, traditional open surgery. And anyway, so this was a proximal chevron that we'd played around with on bone models. And so here, I remember this case very well. I remember walking home to my apartment, our apartment, my wife's in my apartment, after that case, and then the subsequent week or so, I'm thinking, my goodness, here we've done my first ever proximal chevron, never done that before in training. I've put in an absorbable screw here, a poly-L lactic acid screw, letting this patient weight bear immediately in a surgical shoe. And it was one of those, you're not in Kansas anymore, Dorothy, and, you know, wondering if this foot was going to, you know, fall off or blow up or something like that. But nevertheless, here's a follow-up 12 years later. This patient did very well, and I subsequently, that was really the launch of my own personal interest and experience with absorbable screw fixation. Then I returned to the United States, and the screws just happened to be released by a company in 1995, and I started practicing in the United States in 1996. And so anyway, my experience has been all these years, and I'm still fascinated. And I was so excited a few years ago, I guess really now, when Ronit contacted me out of the blue from Israel. She tracked me down here in Spain in about February, I believe, of 2018, so already 2 years ago. And she came in, she flew into Valladolid, Spain, and we started talking about, you know, their interest in doing a clinical trial, and with Dr. Yuri Stalk in Slovenia, orthopedic surgeon, wonderful gentleman and surgeon and friend. And so off we went. So that's where we're going to be heading here, but just a little more history. So even from the hip down, the use of absorbable fixation has been going on and published for many, many, many years. Into hindfoot fusions, people have done their doctoral theses, gotten there and obtained their PhDs on this very material with self-reinforced polylactic acid implants, poly-L lactic acid. And so, although the desire to place metal is not new, really, the industry keeps improving it every generation, just like anything. I always like to think about the evolution of cell phones, the first mobile phones. I remember in college, one of my buddies had one of those first mobile phones. It was the size of a small suitcase plugged into the cigarette lighter in his car, and we thought he was a rock star. Okay, and now we have the technology that we do. Well, absorbables, in an analogous sense, it's kind of mirrored that over the years. So the industry has yet to develop an ideal solution, although, you know, personally, I think, yes, we have, and now OSSIO has. And so now we're excited to roll forward through the pipeline that Chris will be discussing with you and his early experiences, and certainly the results of our clinical trial. So very, very exciting times. If we look at exactly what the OSSIOfiber technology offers, a nice graph to kind of look things up to present have stacked up is kind of the strength versus natural bone regeneration graph. Metal certainly very, very strong. but obviously, again, I've already said, you know, kind of a foreign body to the body, not the ideal marriage or not the harmony between implant and metabolism and physiology. Peak and bioresorbable is not quite as strong. Getting a little bit more into a better marriage of bone plus implant. Biocomposites, taking that even a bit further, okay? And let's see if I can click off of that. And however, what we have up here in the corner, that's really the ideal mixture of strength and allowing natural bone regeneration, is the classification of the OSSIOfiber product, which is a bio-integrative type technology, bio-integrative material. And so this ideal implant really offers the following in this right-hand graph here: metal-like insertion, and it really does feel very good in your hand, tactile sensation, the feel of it, the insertion type feel. It offers sufficient strength for fixation during the healing process. It allows this controlled degradation and integration. This is the perfect harmony, the perfect marriage between the implant and the bone. This is absolutely critical, which has been achieved and never been achieved before. The ability to say and demonstrate and show that there is no inflammatory reactions or sort of intolerance by the body to these implants. And so the ideal implant is really something that we use, and after the job is done, which means what? Means allow a fracture, a fusion, or an osteotomy to heal, that the body then forgets about it, nothing is left behind, and on we go, the patients and ourselves as surgeons and clinicians, with the rest of our lives. These next couple of slides are the meat of innovation. OSSIOfiber, I love looking at them. I love talking about them. If you just look at kind of get down to kind of the nuts and bolts of what the product is, it's a 50% mixture of natural mineral fibers. For example, calcium, silica, magnesium, naturally existing bone mineral fibers, which, by the way, have already been used in vivo and in vitro as bone graft substitutes and other products. And so the safety profile has already been established. And one of the real benefits to doing the clinical trial, and one of the real nice things to be able to share about all that, is that the products have already been safely used in patients. And so that didn't need to be shown anymore. So the actual product itself, the material, is this mixture, and it's a 50% and 50% mixture. 50% mixture of natural mineral fibers and 50% mixture of poly-L-D-lactic acid. So it's a mixture of the isomers or the stereoisomers or the enantiomers. If you go back to some of those headaches from organic chemistry class in college or anywhere else, maybe you studied it like I did in college long ago, but the L form, the levo and the dextro rotatory forms of the chemical molecule. So 50% mixture of biomaterial, 50% mixture of the natural mineral fiber, and then this mineral fiber matrix, where really all these rods, again, this is electron microscopy here, but all these mineral fibers are suspended in the polymer. So basically what we have is we have the screw or pin that is architecturally designed to be all these fibers suspended in the polymer, and then the polymer is going to go ahead and absorb while the bone integrates, and the structure is intact because of the lattice or matrix type network of the fibers. And very, very interesting and fascinating to myself, and with such tremendous potential, is the fact that OSSIO can engineer the architecture and geometry of these implants to anything that is desired. They can be, for example, if we look at the typical forces that might go through bone, you know, bending, torsion, shear, for example, and the forces, flexural forces or loading that may go into the stresses that are applied, for example, in weight bearing to certain implants. Well, those can be quantified, studied, and then the design of specific implants can be applied exactly to the specific needs. So you could imagine, for example, a Jones fracture screw is subjected to different sorts of forces, as is a Jones fracture. And so perhaps the design of that screw implant should mirror that. And that's completely possible. And I think that's just absolutely fascinating and never has been done prior. If you look at this slide over here, you can just see that the surface texture here enables early bone attachment product. And of course, that interface is so important because that allows the product, this 50% natural mineral fiber and 50% biomaterial, to integrate, absorb, go away, hybrid integration. So this is the next slide that really is worth digesting. And that is, if you look at this here, so here's a cross section. The visual representation here by the artist is just phenomenal, but it does take just looking at a moment, which I really enjoy. So right here on this side is the native bone. Here on this side, okay, on this side here is the implant. Okay, this is all native bone. Okay, and so then the structural lattice or matrix type network of the implant allows this osseous integration. So the bone grows into it itself as well. And then the blue arrows is the clearing of that polymer, kind of the glue, okay, the glue that is suspending all these other mineral fibers. And that is all being basically hydrolyzed and being cleared through the pores of the native bone. And this is all just melding or mixing together as this fiber matrix allows the strength and the fluid flow and the bone cell infiltration to eliminate in a very, very controlled fashion the bio component of the implant. So the 50% bio component is eventually disappearing gradually while the bone is growing into the bone mineral matrix, and what's left in a time down the road is just normal bone. Everything's been osseo-integrated. And it's really important to understand that what OSSIO has achieved that no one else has achieved prior, to the best of my knowledge, is this pH balance process. And this is a whole organic chemistry lecture, which I won't give you this evening. But I do like to just explain it briefly, and that is that pH, as we all know, is basically the 14-point scale, and the lower it is, it's acidic, and the higher it is, it's basic, and 7 is the middle, and for example, water is 7. And what really happens here, in a nutshell, is that the absorption characteristics of the product in harmony with bone allows the alkaline byproducts, so the basic, the higher on the pH scale byproducts, to be broken down first, and then as the more acidic byproducts get broken down and degraded, they are neutralized by the alkaline products or byproducts that preceded them. That's all you need to know. That's where the pH balance process comes from, and that's never been done before, because what always happened before was that it was acidic byproducts that were left over. And so even here, when we had conventional reabsorbables or bioreabsorbable products, and in this case, this head-to-head study of a PLDLA-based type pin, you can see here that because it was purely a biomaterial, so it was 100% of that material, excuse me, just gonna get a drink here. So naturally at time 0, the percentage, and actually at time 0, the percentage of it is 100%, right? So then as the time goes along, 52 weeks on to 2 years, 104 weeks, it starts to absorb. Okay, and I used traditional products for many, many, many years, as I said, my entire career, quite frankly, with very, very, very good results. But the reality is that now we have a better mousetrap. So what happened with conventional bioresorbables? Well, once you got over a year and you got down to about 80% of the polymer remaining, then you went into this area here. And this is where the acidic byproducts could cause what's called a burst effect, okay? And this burst effect is what's responsible when it happens, which is not always, of course. It could be even very infrequent, but still the potential there, and definitely happened. to some patients, and they'll get that late inflammatory response or a sterile abscess, or it needs a secondary procedure to trim down a pin or remove more of a head of a screw or do a little incision and drainage. OSSIOfiber, on the other hand, starting at 50% with biomaterial, because the other 50% is the bone mineral matrix, has a much more gradual pH balance degradation type process from the first year and then on to 104 weeks, which is 2 years post, fully integrated into the surrounding bone without adverse inflammatory effects in any adjacent tissue, no adjacent inflammatory cells, no phagocytic infiltration, none of those issues. Just wonderful, wonderful news. And if we look at these kind of head-to-head from the preclinical animal studies, and we go along, we can see this gradual integration again without any adverse inflammation at all. So here we see implantation 13 weeks down the road. We see osseo down on the bottom here. We see nice early bone attachment and ingrowth, and we just don't see any observed integration at all at 13 weeks in the comparison product, which again is this composite of PLDLA. Okay, then at about between 6 months to 1 year out, we're starting to see pronounced new bone and tissue ingrowth with the OSSIOfiber integrative technology. And we're seeing a walling off. Again, that kind of foreign body type reaction from the body to wall off, or something that it doesn't quite really recognize as being, completely biologic or in harmony with the bone around it. As we go on to 78 weeks now, what we see is we start to see remodeled cortical bone with the OSSIOintegrative or bio-integrative technology. And we see the crack propagation, which here we see this is certainly breaking down. It's being hydrolyzed. The crack propagation is that early kind of delamination of the core material, okay? But then when we get out to 104 weeks, what we see here is we see only nature remains with the bio-integrative OSSIOfiber technology, whereas we see this delayed, possibly delayed burst effect with the other materials. Okay, so really this perfect biological marriage between the implant and the bone, so that one day the body can forget it's there, it's completely healed, and everything goes away. If we look at the OSSIOfiber in a little bit of a graph compared to some other options, as well as cortical bone, well, we see OSSIOfiber is 1.5 times stronger than cortical bone itself. So if we look over here, this is cortical bone, healthy cortical bone, and this right here is OSSIOfiber at its start point. Okay, 1.5 times stronger compared to down here. We have peak and conventional bioresorbables. Okay, and then as we go along the graph, down here is weeks after surgery. Okay, so as we get towards 6 months and onward, this is what we want to see. We want to see this perfectly renewed, healthy bone with complete integration as the OSSIOfiber material, and just this perfect harmony. Okay, so as Kim mentioned, I am the co-principal investigator of the clinical trial with Dr. Yuri Stout from Slovenia. This is just a capsule summary of the first human OSSIOfiber hammer toe fixation implant. Hammer toes are hammer toes. We're not cracking chests here. This isn't cardiothoracic surgery, but nevertheless, very, very common procedure. And Chris will take us through what this allows as the initiation for the rest of the pipeline. Okay, again, so this is now basically done, completed at 1 year. We do have 2 patients that we're waiting to see because they were delayed because of the pandemic with the coronavirus. And then we'll be following up everybody at 2 years as well. But this is now done, and it's wonderful to share it with you. So it was 25 subjects enrolled and assessed. Our primary endpoints were fusion, and were there any adverse events. And so 92% radiographic fusion. I can tell you that clinically it was 100% of clinical fusion, but radiographic fusion was, to our the design of the study and to our eye, and also independent reviewers. 50% fusion on radiographs and CT. Secondary point results were basically data collection, okay, foot and ankle mobility measures, showing improvement from baseline, and visual analog scales, the graphs. You can see here the FAAM scores, the activities of daily living, and the visual analog scale score. Okay, excellent results down here. This is the visual analog on the right-hand side here. Here's the foot and ankle ability measures and activities of daily scores at baseline. Okay, and you can see the end results here of them both. Okay, up over 95%, and the visual analog scale here, basically 0. People did really, really well. Let's look at the imaging. So this is one patient followed at each specific follow-up visit within the trial that we did. Okay, so here's pre-op, and then at 2 weeks, obviously all self-explanatory here on the slide, following them at 6 weeks. You can see here, you can see the implant here. You can see here what looks like some early bridging right around here as well. 26 weeks, looking really, really, really good. A year down the road. And then because it's a clinical trial, and thanks to OSSIO and their dedication and commitment to the research to study all this so thoroughly, we were able to do CT scans and follow these up at up to 26 weeks post CT scans. I love these pictures. We never have CT scans to look at for hammer toe surgery and actually confirm and see what we kind of already know is happening, but it's nice to see it confirmed. So just look at this beautiful consolidation at 26 weeks confirmed by scan. And then the MRIs, and I just love this. So we're only, we just got the MRIs recently because we're doing the 1-year follow-up. So you see here, particularly, you see absolutely no adjacent inflammatory reactions at all. And look at this. To me, this is just robust cortical healing. Okay, look, it's complete continuity with the cortex of the middle phalanx and the proximal phalanx, even thickened because it's all new bone due to, being laid down around the fusion. This is just really cool to see. And here, the implant as well. So, this is 52 weeks. We know from the animal studies that the implants disappeared in animal studies at 104 weeks after surgery, which is 2 years. So this is halfway there with the results to date. And again, all externally reviewed by independent people, not involved with the study. Not just, myself, hey, these look great. And we'll be following up all the patients at 2 years after as well. So I'll stop there. I think, Kim, we can field questions if people would like at this point, some questions pertinent to my portion. Then we'll go right on to Chris to share his experiences, plus what's really exciting coming down the road with the pipeline.
Yeah, absolutely. Thanks, Dr. Cicchinelli. For folks that have questions, there's a Q&A button on the bottom of your screen. Please feel free to type your question, send it along. The panelists will be able to see that. Dr. Cicchinelli, I'm going to field the first question for you.
That'd be great.
It's in regards to the potential for allergic reactions, specifically either to the material or for the natural mineral fiber components as well.
Okay, so essentially none. The bone mineral fibers are naturally occurring bone mineral fibers that we all have in our bodies as well. And then to the biomaterials, there is no real allergic reaction. No allergic reaction has ever been demonstrated to those biomaterials in immunological or immune-mediated sense, okay, such as IgM, IgE, those types of things, immunoglobulins. That's never been demonstrated. So the potential for a foreign body-like reaction certainly existed with biomaterials. Certainly that was a major issue with polyglycolic acid, PGA. And then in the body of the lecture that I just gave, that burst reaction with the acidic byproducts, degradation toward the very late stages of bioabsorption or biodegradation of materials, did allow the potential for some foreign body type reaction. Again, it was not an allergic reaction, foreign body type reaction in a small, very small number of patients, but nevertheless a possibility. So specific to OSSIOfiber and OSSIO-integrative technology, which we're sharing this evening, the answer is no, not at all. And again, for all the reasons just discussed, starting off with the fact that it's actually a 50-50 mixture prior to implantation, and that 50-50 mixture allows this gradual pH-balanced absorption process to go on over the next 2 years after implantation.
Yeah, this is Chris. I'm just going to pipe in real quick. I think it's a great question. It's actually one of the best indications to use one of these integrative type of implants. Is, you know, there are a fair number of people that have metal allergies, nickel allergies, or they've even if it's not a diagnosed allergy, they seem to have reacted to metal implants and K-wires before. So it's one of the early reasons I started looking for some other type of implant, because all the other hammer toe devices, for example, or for the most part, are titanium or steel or something like that. So I think it's a great indication for use. The other thing that I would say, not even all that scientifically, is just looking at the foot, looking at the patient over those, first couple weeks, first couple months. It's just remarkably quiet, which just kind of tells you the things inside are getting along pretty good. And that's not something that I would see when I'd have K-wire sticking out of the toes. The toes are always swollen and sausagey and kind of angry looking. And you just don't see that with this material. So, which is really a nice kind of side benefit, I would say, as well.
Those are wonderful points, Chris. And I will just add that one thing I've noticed routinely, without exception, never, without exception, over 25 years plus now, well, 1994 to present, so what's that, 26 years, that patients, when I have told them, which I have, hundreds and hundreds of times, that I could perform their procedure with bioresorbable type products versus metal, there's never been a single patient that told me they would prefer metal. Patients just intuitively understand, even better than surgeons, quite frankly, in around the world, and then certain surgical communities around the world embrace biomaterial and always have more rapidly than others. I think just due to tendencies and perhaps conditioning and training and patterns and things like that. But nevertheless, patients get it. Just the fact they just get it, like they get that it's an absorbable suture, has got to be better than a suture you have to take out. They understand that some sort of implants that will eventually be integrated into the body or absorbed and go away, and there's no need to worry about them down the future, that just makes perfect sense. And then specific to what Chris said about hammer toes, these products that are all inside versus traditional K-wires, of course, they just allow us to get patients back into closed shoe gear faster. Therefore, edema is avoided rather than having edema you then try to later get rid of, and you're able to rehab patients faster and everything. In addition to the more quiescent effect of it that Chris is seeing, and I have as well, the initial several weeks after surgery, they just look better and feel better.
That's great. Thank you, Dr. Cicchinelli. Thank you, Dr. Hyer, for comments there. Let's take this one last question before we go to Dr. Hyer's presentation. I think this will be teed up very nicely. One of the attendees wrote, I recently had a case where the patient sustained trauma to her digit that I repaired approximately 2 years ago with a hammer toe implant. The implant was steel and it was fractured. He said they had a difficult time removing it. With the OSSIOfiber implants, what's the removal process if it does need to be removed?
Well, I'll start first, and then Chris, please respond as well. So haven't seen that happen yet, but if it did, there would be between no need to remove it at all or simply cut through the area and re-drill and put another implant in. It would depend on how far down the road that complication happened. If it was 2 years down the road, well, probably that doesn't exist because the implant has already osseointegrated. If it was some sort of issue, 2 months to 4 months or within the first year, well, the clinical decision would be made based on the presenting circumstances. But that's always been another one of the benefits to absorbables and these types of products, is that any sort of revision, if should it ever be necessary, is even easier. I can remember a few cases of mine that I had what I would term kind of minor complications. I remember a lapidus type procedure many years ago that I did with polyallolactic acid screws that the patient went on to develop a Charcot type deformity through the midfoot. And I had to revise it. And I was able to just basically cut through the area, re-drill, putting new screws in and things like that. So it's all much more manageable and bio-friendly due to the nature of the materials versus metal or metallic products.
Yeah, I would echo that. I would say exactly what Luke was saying. Kind of would depend on when it happened or when it had a failure. I think what you see with the histology and some of the slides that Luke already showed, that the bone is growing around and through, eventually through it, but around it, and so there's already bone stability. So the implant, after a while, is really not all that relevant, and so you don't get the same stress shielding problem like you do with a metal implant. So that's the problem. Sometimes when the metal implant fails, there's no stability because the bone sometimes didn't really grow around it or didn't have that. And so then you're really kind of stuck with a problem of, how do I revise this? I've got this broken piece of metal in there. I would venture to guess, I haven't seen any of these fail either, but I would venture to guess that if it somehow failed or broke, the bone's already healed around it. So it's kind of beside the point. Something that I'll go into in a second with the other products, something that I've been very amazed by is the strength of this material. I mean, you can hold this in your hand, you can hold these pins in your hand, and I dare you to try to break it. It's really, really robust. And to Luke's point, you can cut it with a sagittal saw. And so that's what I would think if I had a solid fusion or malunion maybe of a hammer toe for some reason, and the implant was still in there, and I had to revise it. You could take a sagittal saw right through it, and then you'd cut it in half, and then I guess you could bookend it and take it out or drill through it or something if it was still there. But I would, at least in my experience, I haven't had that problem yet, and I think it would be much easier to deal with than a metal implant. You certainly wouldn't be nearly as destructive as you are when you have to take out a metallic one that you're basically having to chisel the bone away to get the metallic one out of there.
That feel as well that you're talking about, is just how you would be you wouldn't even be able to break it yourself with your hand.
No.
Also,
I tried.
Yeah.
I tried. I was humiliated. I tried. I was like, oh yeah, I'm going to snap this thing. I couldn't do it.
Well, it also gives the surgeons the comfort of that metal-like feel on insertion, because, especially foot surgery, people go by tactile feel, and some people with bigger screws or maybe ankle fracture and maybe some hindfoot procedures might be drilling screws in, and some perhaps in the forefoot as well. And then others like to just put screws in manually in the forefoot and then maybe on power in the hindfoot or ankle. But nevertheless, that feel of the product going into the bone as well is worth a lot. You don't have this feel that you're putting in some flimsy type material that you could probably snap in your own hand,
Exactly. Yeah, absolutely.
Great. Thank you guys both. Dr. Hyer, why don't we tee your presentation up? Dr. Cicchinelli, if you don't mind, we'll have you stop sharing, and then Dr. Hyer will have you take over and share your.
All right. Well, thanks. Thanks again for the invitation. Luke, I really enjoyed that presentation. I absolutely hated organic chemistry in college, and you actually you held my attention. It was actually really interesting. I hadn't seen some of those slides before either, so it's really you really understand that material well, which is great. Yeah, me and my partners, were introduced to OSSIO as a company probably, I don't know, maybe 4 years ago, before there was even really a product out. And just to really hear the science and the expertise behind this material, as Luke really alluded and demonstrated, but to hear that from all the scientists and the engineers that have been involved with this company from the beginning, it was really amazing. And I think that those pictures you showed with the lattice work of how the materials are interlaced together, and then to feel this material in your hands and see how robust it is, I really, I'd say I was kind of skeptical at first. All my experience with biocomposites and bioabsorbables was they were always kind of flimsy or fragile or really brittle. And this is just kind of nothing like any of those other products out there. So we've had some good, let me see here. Mine's not going. Here we go. We had some experience with the hammer toe product, but which was already shown, and that's been the first commercially available product in the U.S. But I was able to, and so was Luke. But of some of the surgeons here that have been working with the company, have been able to get our hands on some of these other products that are coming down the pipeline pretty quickly. And again, this is where you really, I think, appreciate the strength of the material and then the versatility of it, and how the company has ability to weave and manufacture this material into all different types of applications. Maybe people don't get all that excited about hammer toes, but I think the option, what we've really seen a lot of success with the hammer toe implant is just like that I was alluding to before, is that I have the strength and stability of a metal implant that isn't there permanently, and also something that doesn't have to stick out of the end of the toe, which causes a lot of hysteria in patients, anxiety in patients, and I honestly think the times that I have the percutaneous wires, I'm getting these congested, swollen toes, which we just don't see with the implant. Even taking it to the next step, some of these fixation nails and the compression screws that are coming soon, this is where I think a lot of people are going to be kind of wowed and amazed by the material, both on its strength, as we talked about before. The biology will be exactly the same. The materials are the same as we saw with Luke's presentation. So that integrative type of mirror or molding and integrating with the bone is still going to happen, but just the strength is going to be pretty amazing. I've been placing these in cadavers in some of the early studies, and even in cadaver bone, which is notoriously pretty poor, these devices hold quite well. And again, you can't make them fail. You have to cut through them with a saw if you want to try to force it to fail. So just to kind of give you an idea, we're going to see these trimmable fixation nails that are kind of ribbed, and we'll see that in a little second. Compression screws of various sizes, and even fixation plates and staples are going to be coming down the pike as well. So, this is a material, we're just kind of introducing it to you guys in the hammer toe market and the foot and ankle market, but it's almost limitless with where this material can be used, both in sports and other applications. So I think kind of the point of this slide is kind of keep your eyes open, because it is almost kind of limitless on where it's going to be used. So in the U.S. at least, the hammer toe products out there, it's already been released. It's FDA approved. There are now these other sizes that are now out on the market as well, which is good. Gives us a versatility between patient size and even the size of the toe, either go in a larger diameter and potentially a longer length as you get into the larger size. And again, now there's an angled and a straight, and some of that's surgeon preference. I tend to prefer the angled implant. I think that kind of cuts down on the chance of mallet toe or flexion contracture long term, rather than having a dead straight PIP joint. But again, that's surgeon choice. These are all sterile, packaged, sterile produced, and it comes with sterile instrument kits too. So more than ever, I think in the age of COVID, at least in the U.S. here, maybe Luke, you can speak to this earlier or later too, but least in the US, there's a huge swing happening about having sterile implants, instrumentation packets, and limiting people in the OR, including reps. So, having these things that are kind of an all-in-one package just makes this even easier to deal with. Again, the point too is, this material is very easy to insert. It's pretty simple technique, kind of similar to other intramedullary hammer toe devices. So a little pilot hole on either side of the joint after you've done your resection. You'll see that the drill bit has two different marks on it. So the deeper mark goes in the proximal phalanx, the shallower one goes in the middle phalanx, and then you manually insert this. It has these kind of ribbed designs to it, these little flares. So even in parodic bone, I find that this fits, that has a little bit of resistance, and you see that the flares are angled so it'll let it advance, but will resist it trying to back out. And then you do kind of a manual docking and compression of the implant. And this is where I think they were smart to increase, having some variable length. You sometimes you have some anatomy changes in people, and sometimes, I wanted to have that middle phalanx a little longer or a little shorter. This allows you to do that. Again, with the implant, being trimmable, not metal, if you get this into the proximal phalanx and you find that that's the perfect size and you just can't get the middle phalanx over to dock it, you could always trim it off a little bit with a saw if you needed to without necessarily taking more bone away, which again is not even a possibility with the metal implant. And then when you kind of manually dock this, I pretty much try to do this as hard as I can. You just do a manual compression. Sometimes you'll even feel it kind of click, and then it's very much kind of locked in place. I've kind of found that actually when it's in the bone for a little bit and has some fluid around it and blood around it, it actually seems to kind of engage even better. So I think it probably absorbs a little fluid and just swells a little bit, and that even locks it in tighter. So it's a pretty robust, connection that you get there. This is kind of give you a glimpse of the trimmable fixation nail that's coming soon. I was asked by some of the company people, don't promise it next week or anything, but it was due to be very soon, but obviously shipping and everything else like that has been kind of curveballed a little bit, but I think you can expect this by the end of the summer or midsummer even. So I'll let the company guys chime in here in a little bit on that. But so again, looking at these trimmable fixation nails, this is really designed with kind of the forefoot, midfoot in mind, with forefoot osteotomies, bunionectomies, even fusions, like the 4.0 might be used for fusions with an MTP or Lapidus. So you'll see that there's a couple different options there, from a 2.4 or a 30 millimeter with 2 implants provided versus a 2.4 with a 50 length. And so the idea is, maybe you would want to use a long 50 for something, or even divide the 50 into 225s. You can do that again with the saw if you wanted to. So same fiber technology that Luke showed you with the lattice work, the barbs that give you this good robust fixation into the bone that's tapered, so it lets you insert it manually. And then that hexagonal kind of shape too. Again, it just kind of locks into the bone. It's kind of remarkable how stable it is. And then again, the disposable kits, instrumentation kit to try to make this easy. As Luke was talking about earlier too, a lot about this material, the implants, and even the instrumentation kits is really to kind of mimic the way we already do these surgeries with metal implants. So we're not kind of changing how we do things or changing the techniques. It's still your AO principles. You can still use temporary fixation with a wire. You can. We've made these with a cannulated technique, even though the pins, or the nails, I should say, are solid. So you can put in your K-wire. You can use your drill, cannulated drill. You can use a manual depth gauge. And then it really comes to step 3 there, whether you want to trim the implant to size that you've measured and insert it flush, or you can insert it long and measured and then just trim it off with a saw, so that you can really kind of do either way. It's very easy to do either technique kind of however you want it. And then again, you could go side by side with the second implant for that rotational stability as well. So in very much many ways, this will mimic that stability and fixation strength that you would have with screws. And again, they're going to have the headless screw version as option as well, coming down a little bit later, but these fixation nails will be coming first. Full disclosure for me, as I was getting to look at both of these options, I was going into the cadaver labs thinking, well, I have no interest in these nails. I mean, I just want a screw. I know how to use a screw. Screw's going to be way stronger. And I've flipped 180 degrees. I think these nails are incredibly robust. They're actually very simple to put in because you're just kind of manually tapping them in without having to use a screw or screwdriver. And so I've actually been converted to probably be a nailer, not a screwer. Sorry. This is just some of the animal studies. Again, more of the data that the company spent time and effort really proving this out in fracture models even. So this is a large bone fracture model, weight bearing in a sheep. So there's not, they're not, this is going to simulate your non-compliant patient who's, weight bearing on it right away. But this is an osteotomy that was then fixated with the headless screw version of the material. And so you can see very similar to kind of what Luke was showing is you see stability of the osteotomy. The osteotomy heals. The implant is maintained its strength through that 6-month period. So the osteotomy is healed, and we haven't had degradation in a meaningful way yet of the implant. There's no drainage or anything like that. It's provided the stability it needed to provide, and then over time, that the bone will then start to integrate through the implant. So again, it's kind of the best of both worlds. You have the stability and the strength of what a metal implant would give you, and then you have that biocompatibility of the material becoming bone essentially over time, but not until after the osteotomy or the fusion is gone on to heal. So to kind of just show you, some more cross sections with the micro CT. Again, you can see kind of complete healing of the osteotomy. You don't see a lot of lysis around the implant or anything like that. It's not backing out or draining or anything like that at 6 months. So again, it's staying very quiet and providing strength and stability through that time. And then you'll see how it becomes kind of integrated later. So this is a kind of a simulated plate. This is not something that's out yet. But just to kind of show you the simulated plate with the OSSIOfiber material. So those are standard metal screws to anchor it down. You can kind of see it's a slightly radiolucent there for the plate type material. And I think pictures speak 1,000 words. I think this cross-sectional analysis of how the plate reacts with the bone over time, I think is really impressive. So you see it, at a year, the implant is starting to remodel, but at 26 weeks, it's still very much stable and has provided stability for that entire time. At a year, you start to see it kind of start to degrade or integrate a little bit. And then if you look at it a year and a half, look at 78 weeks, you really can't tell where the implant was. It's become the bone and that have molded together and incorporated, and you have a complete remodeling there, almost like there was never anything there before. And so it's just amazing to me when you see that versus how our early experience with bioabsorbable implants, where if you've ever MRI'd one of those bioabsorbable screws or the thing over time, sometimes you'll just see a hole there. It just disappeared. It dissolved, but nothing else replaced it. And that's just not what you see with this material. It really is a very, as Luke said, a very good pairing of the biology of how as it's replaced, it becomes bone. It's pretty amazing. So we're not going to be limited to just pins, nails, screws, even plates. They're already got some prototypes with soft tissue anchors, which make a lot of sense. Obviously, there's a lot of those that need to be used, and that makes a lot of sense for something to have a lot of strength for a good period of time and then incorporate into bone. And then even staples. We trialed some prototypes of this when we were at ACFAS here a couple months ago, pre-COVID, I guess, PC. And again, just shockingly strong. I was really surprised. When they said, "Hey, try the staple, see if you can pull the joint apart, see if it, breaks or springs apart," and it's just amazingly strong material that then becomes integrated. So again, pretty exciting stuff. It's not often that we get implants and materials that are really groundbreaking, exciting material like this. There's a lot of Me Too. We kind of get used to the fact that it's a screw, it's a pin, they're all the same. And this is really just a whole new world. So I don't pretend to be smart enough to understand all the biology and histology of it as some of the scientists that have been working on this with them. But it's just it's really going to kind of change, I think, how we think about even what we do in surgery. I think what I get pretty excited about it is when you start to think about square area of your fusion mass or your fracture healing mass, right? We think of an ankle fusion, and you think of the square area of the tibial talar joint, and then we put 3 huge 7/0 or 6/5 screws through there, and you've probably taken up 15, 18, 20% of the joint space just with hardware that doesn't ever heal into bone. And to be able to have that same strength and construct, but then becomes part of the eventual fusion, you'd have 100% fusions instead of fusions and fractures that always remain implant. So it just kind of changes how we think about things. And if you can have the best of both worlds with the strength and now the bio-integrative portion of it, it's pretty exciting. So I think we'll open that to questions too. I tried to hopefully go through that relatively fast, but give you guys chances to ask us other questions as well.
Yeah, thank you, Dr. Hyer. I got the first question here. We have a surgeon asking, how do you anticipate viewing if a plate or screw breaks when it may not show up on X-ray well?
Yeah, good point. A good question. So I guess the question would be, why would it break, and if that is that a problem or not? I don't know that we would want to necessarily have some kind of metal markers or in it or anything like that. I kind of see probably a lot of us as we start to use these materials and fusions. I think all of us we're creatures of habit. We're going to be probably a little slow to fully change over, and I could see what we're probably going to do is do some hybrid fixation at first. I think a lot of surgeons will probably use the OSSIOfiber screws or nails across joints, and then maybe still put a plate or something around the outside of it until they really can see how great it works. I don't know if there's a real good answer for seeing it, if it's broken, being able to tell that other than going to advanced imaging. You can see it quite well on the CT scan and the MRI. You can see it a little bit on X-ray, and I think if you probably modified your X-ray KVP and things, you could probably pick it up a little bit easier, but it definitely shows up on a CT scan quite well.
Perfect. Thanks, Dr. Hyer. The next question is, can you talk about what hammer toe implants you guys were using before and why you transitioned to OSSIOfiber and what that experience has been?
Sure. I'll give you my answer first, and then Luke can pipe in too. So I was probably, I don't know, I'd say probably maybe 50-50 or 70-30, either still K-wires, so percutaneous 0.62 K-wire out the end of the toe. And then the other half was intramedullary metal implant. And kind of my pros and cons of both. The K-wire was maybe a little bit faster sometimes to do. Definitely a little less expensive, so sometimes that was an advantageous point. But a lot of patients did not like the idea of having a K-wire sticking out of their toe. Like I said, the toe would be sausagey and kind of swollen a lot longer, I thought. And then there was always this anxiety of that 4-week, 6-week visit to go ahead and take the pin out. So that really kind of started to steer me towards implants a lot more. The metal implant, can work fairly well. I've had some pretty decent experience with that. I think the downsides of it is I've had a fair amount of them cut out over time. And I think that goes back to that stress shielding point I made earlier. I think even at a year or 2 years, sometimes as you're walking and your toes flexing up against it, I've had some of these kind of bladed type of hammer toe implants kind of crack through the bone, and that can become a problem. And then, as the previous question asked, then that's a tougher vision because you have an implant that's already been in the bone for a while. So when we had this opportunity with the OSSIOfiber hammer toe, to me, again, I come back to that idea of kind of best of both worlds. I could have something that would give me the stability of the metal implant without being sticking out of the toe. I have something that's not going to be a problem long term because it's going to integrate over time, and that's where we've gone. My only limiting factor with the OSSIOfiber implant prior to now was we only had one size for a while. So if we had kind of the smaller size at first. And so if I had a really big toe or long toe, I ran into a few where I would put the implant in and I'm like, oh, it's just not long enough. It's not grabbing enough bone to feel really stable. And so I had to go a little slow with those at first, but that's been rectified. Now we've got both a wider and a longer implant. It really gives you a good versatility.
I can just add as well my experience. So I went to all inside techniques years ago, still occasionally external K-wires in cases of revisions or particularly where I was trying to avoid any rotation. So I will occasionally put in two very small, like 1.1 K-wires parallel to each other to avoid rotation. But I'm talking, under 5% of cases. So and the other 95% I have been using since 2001, or actually 2003, the PLLA pin. So with an all-inside technique. And my criteria really has been try to make it bio for hammer toes, try to make it bio, all inside, and allow a flexed fusion of 10 to 15 degrees. Or as you desire at the end of a procedure, simulating weight bearing before you put on the dressing. And so now OSSIOfiber technology allows the very exact same thing now that the full line with the flexed or angled implants is available with the improved, again, I actually don't have an iPhone, but iPhone 10 or whatever the number is versus iPhone 1, okay? The latest generation of the highest performing material is what you have now compared to previous generations. And I always like to say, we're all friends and we're all, I feel pretty objective and fair and kind of, balanced in what we do. It's not that previous things don't work. It's not that previous wasn't good and we had all these incredible disasters. Quite frankly, that was never my experience. My experience is we're always trying to polish the diamond. We're always trying to improve, be it in our personal lives, our professional lives, hobbies, our work, whatever it may be. And this is the natural evolution of anything. And this is the crest of the wave, so to speak. This is the cutting edge. The newest technology is here. It's really exciting. I'll just take a quick opportunity to mention something that Chris said about the pictures with the plate on the surface of the bone. I agree. Fascinating. To me, that is just like nirvana for what we do. And having been interested in this for so long, I at one point had read all the articles when I did a few publications myself. I had read all the articles from the basic science up into the clinical application of the original Finnish surgeons and a lot of veterinary surgery models and so forth. The reality is that bio always depended on being implanted in bone, not on the surface of bone, because it required hydrolysis, and still does, requires hydrolysis to break down. And so this required, vascularity and body fluids, let's just say, to interact and start to, as the implant started to degrade, to start to penetrate and assist in the absorption. So what is so fascinating to see here is that the plate on the surface of bone has still created this osseo-integrative effect that was unimaginable prior. Mm-hmm. And the only other comparison I can give you is that in pediatric maxillofacial surgery, absorbable plates have a role and are used quite a bit. And when I used to lecture on all this back in the United States years ago, and it was just pure poly-L-lactic acid or blends of PGA and PLLA, people would still ask, about reactions and so forth. And the only reaction I could ever find to a plate was a child who had a late complication where a plate extruded through the skin. It was like a mandibular fracture for a congenital deformity. And it was, it wasn't common, but it happened. And it was like logically possible because the implant was on the surface of bone. There was no real, bony tissue, vascularity helping to facilitate the degradation of the product. So when I see this plate, the OSSIOfiber plate on the surface of bone, I see the histology, it just blows me away. I'm just like, okay, the future is here because, at time zero, it's 50-50, 50% bone mineral, 50%, bio. And here we have histology where it's, it's absorbed into the bone. It's just fascinating. It's just the potential is limitless.
Mm-hmm.
I appreciate that. We have a few more questions, so I suggest we do a little bit of a lightning round. I'm going to make sure we get these answered. The first one says, you may be converting, whether it's hammer toe or some of the other applications in the pipeline, from metal implants to OSSIOfiber implants. What do you two see as a perceived value OSSIOfiber has over metal, and what consideration does price pay in that?
Yeah, that's a valid question. Good question. Thanks for that one. So I think a couple things. One, you don't have to worry about any kind of metal allergy, which is rare, but that's not even on the radar. Number two, I think to Luke's point, patients, my experience at least, patients love the idea of something that's more natural, more integrating, not this kind of foreign metal material that could sometimes, be a problem for them. Shockingly, at least in our experience, the metal hammer toe implants have been fairly expensive too. So I think the companies, at least in our experience, has been pretty reasonable about pricing the hammer toe implant so that it's easy, reasonable for us to get it into surgery centers and hospitals and things of that nature. And I think, the other advantage there, again, against K-wire is, there's really not that chance of any kind of infection or a K-wire that's getting painful or loose, so that it might have to have some other care given to it. So it's been a pretty easy transition in our market, even in the surgery center market, for us to convert over to the OSSIOfiber away from intramedullary metal implants.
Regarding I think a part of the tenor of the question was price and perhaps, screws of, the OSSIOfiber screws as they come along, and how might you transition from metal and the cost considerations. Absolutely, cost is a consideration worldwide. I always think it's nice to remember there was an article published years ago that looked at what was called the hospital economic resource consumption, or consumption of economic resources on biodegradable versus metal. And the percentage was really 31%. And so if you removed or had any sort of need for removal of internal fixation in only a third of your cases, there was actually a financial benefit to using absorbable or resorbable technology. So personally, I think that type of study needs to be championed again and repeated and applied to current day healthcare economics. I think that's just fair and good business to do that for everybody involved. I think product companies, of course, need to be cognizant and aware and sensitive to pricing issues. I do also think that, you know, this post-coronavirus, I don't know if we should say world, but at least let's say, you know, going forward, I think, you know, something that's trimmable, you know, modifiable, one size may not fit all, but one size can fit 100 versus everybody wants their version of a screw length. And, you know, I got to have 22 to 28, and they got to be in 2 millimeter increments. And your partner, who's one office down the hallway, goes, "You got to be kidding me. You're crazy. I need 3 millimeter increments, and they have to be odd numbers." And then the next guy over says something else. You know, all that goes away.
Yeah.
When you have the trimmable implants that are, you know, you put in a 50 millimeter nail, and that's your nail for anything under, you know, 48 millimeters in length. So it's like any adjustment or transition. We all will work with it in process and go forward together and share experiences. And what we currently do or what we did in the past gets phased out by what we now do next.
Sure, absolutely. Yeah, the utility of the product is definitely a key consideration as well. 2 more questions. First one is, what would you do if you have a crossover toe and need to stabilize across the MPJ?
Yeah, absolutely. So that's a really good point, because that was something when we started using intramedullary metal hammer toes here in the States. And if you're used to using a K-wire down the pike to stabilize the MTP joint, you know, all of a sudden you're kind of taking that option out of your hand. So I think even going through that learning curve a little bit, realizing that, and we've all tried that technique, right? Pin across the MTP joint, that's going to take over the crossover toe, to only pull that pin out at 6 weeks, and the toe goes right back where it came from. So I think we've all kind of woken, or further, worst, yeah. So I think we've all woken up to the idea that you've got to do proper soft tissue balancing. We've got to do, you know, plantar plate if that's what it needs, you know, collateral ligament repairs if that's what it needs. And, you know, I'll have to give, I hope he's not on this call, because I hate to give my partners credit sometimes, but you know, I have to give my partner Greg Burlett, you know, some credit, because I was definitely a pin across the MTP with plantar plate repairs and things of that nature, and I've been doing less of that in the last year, and just doing more soft tissue anchors if I need some extra stability there. So having an intramedullary implant like the OSSIOfiber would be really doesn't change my crossover toe correction anymore, because I'm not relying on that pin across the MTP joint. It just doesn't, by itself, doesn't really gain you anything anymore once you kind of understand the balancing of that soft tissue around the joint. How about you, Luke?
Yeah, I'll jump in on that because it's a very common question. So one of my core principles as an educator is that if someone's doing something that works well in their hands, then please keep doing that. If it's a certain procedure that someone is really comfortable with and has no complaints and patients are happy and people are doing well. So for someone who routinely feels the need to cross a metatarsal phalangeal joint with a K-wire for their procedure, for their patients, I would continue to do that. This product will fit for the toe, but it's not going to help you cross the metatarsal phalangeal joint. So in that subset of patients, you're still going to be using a K-wire. However, I don't cross MTP joints anymore either, and haven't for years. And so everything that Chris said, plus what I've always termed longitudinal decompression, which I borrow from the Baruch world of lesser metatarsal osteotomies, to decompress those soft tissues. So again, everything Chris said, plus the consideration of shortening metatarsal osteotomies of whatever type, WIO or otherwise, to decompress the soft tissues. Because really, when we have done all the soft tissue releases, we have a hammer toe straightened, the PIP joint fused intraoperatively, if there is residual metatarsal phalangeal joint contracture, what it really signifies is there's still some sort of pathological anatomy or pathoanatomy. So it's either plantar plate is still torn, soft tissue contracture, dorsal skin contracture. There's something that still needs to be addressed. And so I look for why does it still seem to be up in the air at the metatarsal phalangeal joint? And I seek to correct that rather than cross the metatarsal phalangeal joint with a pin.
Great answers, thank you. Last question here we have is, have either of you noticed that in the early post-op phase, specifically in the first 4 weeks, that patients have reported less pain than with metallic implants, whether that's a K-wire or a specific hammer toe device? They say, with less inflammation or reaction may have been noted. They're wondering specifically if pain is less because the material, so osteofiber material against bone, is sensed different than metal against bone. Thoughts?
Yeah, that's interesting. I have noticed less pain. That's kind of what I was alluding to earlier about the toe. In the case of the hammer toe implant, the toe is just kind of quiet, doesn't seem very angry or swollen, and obviously that would mean less pain too. I think part of that is that there's stability from the implant, so you need to have stability of the fixation, and that's a key part. I think that idea of how it's sensed within the bone, there probably is something to that. I can't speak intellectually on that because that's the bio histology part. But I think a lot of what you saw with Luke's talk on how that material, it's not really doing a lot yet at 4 weeks, but it's also not reacting negatively against the bone at 4 weeks either.
So I completely agree, and I'll add, and I'll share one of my favorite lines, and that is that the eye only sees what the mind knows. And what I mean by that is that psychology and what you see is based on what you're conditioned to see and what you're used to seeing, what you're used to feeling. And so when you show patients x-rays of their foot operated on and they don't see anything on them, they don't see pins and screws, and they don't ask you those questions. Oh, and I'm going to send off the marker in security in the airport, and they don't have all these questions. They already feel better. Now, I'm not a psychologist or a behavioral scientist, and I won't pretend to be able to explain to you, where, why, how they're processing that. But I know it's true because I've seen it for years and years and years. And then there is, I believe, I don't believe, I know that there's this better harmony, this better biological marriage between the implant and the bone. We've all had patients who have metal fixation, okay? My own daughter, okay? I just took plates and screws out of her ankle, okay? She broke her ankle 2 years ago. ORIF, trimalleolar, the whole 9 yards, did great, but 2 years, hey, geez, the screws are bothering me, and she's 18 now, and but we've heard this from patients for years, even with devices which all your imaging show are not prominent, they're not protruding, there's no soft tissues, irritation, it could even be almost intramedullary, like a screw, intramedullary or a Jones fracture or something. So yes, people have less pain. I think they physically have less pain, and they psychologically have less pain. And postoperative pain, by the way, is absolutely a mix of physical and psychological pain. There's no doubt about that. Mm-hmm. That's been studied for sure.
Mm-hmm. Yeah, that's a good point. I hadn't even thought about that point about what you were saying, the post-op X-ray, and oh my God, what's that screw on my foot? We already talked about that, remember? And I didn't even think about that. You're right. That it just looks that there's not all those other points of anxiety that could be brought up because you're not seeing all this material in there. So that's a good point.
All right, I promise this is the last one. We've had such great questions come through the feed, so I want to make sure we answer all of them.
No problem.
Can it be used in the presence of bone infection? Would you guys stabilize 2 segments of bone when one has been resected, and if you're unsure if there's a clear proximal margin?
I'll jump in
So if
right
one
there.
has been resected and unsure about a clear. Okay, sorry.
So I would just say no. If I'm uncertain about infection or some sort of, internal derangement or biological or rheumatological acute type scenario, then I would most likely, quite frankly, do percutaneous fixation so that I can always retrieve and leave nothing in there. I do that both maybe in a medical legal sense, but I also do it in a practicality sense, and right back to what I just said about patient psychology. I'm a huge believer in patient psychology. We're all just a bag of, gray matter and emotions and, tendencies and conditioning. I would percute that. I would not put an implant, metal or bio, in something that I wasn't quite sure what the biology was.
Yeah, I would agree with that. I think if you have suspicion of infection, leaving a permanent, even a semi-permanent implant like this, in there probably isn't a good idea. So I think if I had cleared infection, and could prove, that I've cleared infection, I wouldn't have any problem putting this in there. But I think if I still am suspecting infection or can't know for sure, I'd probably go what you said, go with a percutaneous, because I'd probably pack an antibiotic powder and everything else in there at the same time too. So
Now, it does bring up an interesting segue, which is I'd love to share because it was one of the most fascinating things that struck my mind back in the late 90s when I was reading every article that came out on this stuff. And that is that there is believed to, and also, by the way, Chris, you got fellows and this and that. It'd be great to put someone on this as a research project. But there was excellent literature that the incidence of infection was less with bioabsorbable fixation because it does absorb and it does degrade, and therefore there's less opportunity for a glycocalyx formation or a bio-slime layer to form on the surface of something that is degrading. And as it's degrading by hydrolysis and by, back to that pH slide, but the acidic degradation and so forth, this essentially is kind of antibacterial. So that's a fascinating little thing that someone should, pull the cover off uh, and compare. And now let's be frank too. The rate of infection in clean orthopedic non-contaminated surgery, is like under 1%, right? But nevertheless, that's a very interesting at the cellular, molecular biology, infectious disease level, really a very interesting consideration to know that already has been looked at. And now with a material that's 50-50 bone mineral fibers and bio, copolymers at Implant, be fascinating to look at that again.
Perfect. Thank you, Dr. Cicchinelli. Thank you, Dr. Hyer, for your
yeah,
time. We
thank you.
really appreciate you
Our pleasure.
joining and presenting and answering all of these questions.
Yeah, thanks to the attendees for all the questions. Those were great. Really smart questions. Yeah.
This has been super.
Likewise. Thank you, everyone, for joining. We really appreciate it. And take care. Have a great night, everyone.
Thank you very much. Chris,
Yeah,
nice to see you. Stay
absolutely,
well.
man. You too. Good seeing you.
Yep, you guys as
Thanks.
well. Good night. Buenas noches.